introduce Dr. June Bredin and Dr. Cindy Grande on the topic Buprenorphine Model of Care, How to Meet the Needs of Patients and Providers. Dr. June Bredin is a family physician, faculty member, and medical student education coordinator at the FHQC Family Medicine Rural Residency Training Track in Ellensburg, Washington. Her practice includes 2 Suboxone medication-assisted treatment clinics weekly in a team setting that includes integrated behavioral health. Since late 2019, FHQC has been providing medication-assisted treatment services to inmates at the Kittitas County Jail. Since the onset of COVID, the FHQC has also developed guidelines for providing telehealth visits as part of the program. Dr. Lucinda Grande received her medical degree at the University of Washington, completed residency training at St. Peter Family Medicine in 2011, then joined Pioneer Family Practice in Lacey, where she has been prescribing buprenorphine since 2012. She is a co-founder and medical director of the Olympia Bupe Clinic, a low-barrier buprenorphine clinic. As a UW Department of Family Medicine clinical assistant professor, she helps train third-year medical students in both the primary care and low-barrier buprenorphine settings. June and Cindy, thank you very much for leading this very interesting presentation. I'm excited to learn from you about this. Thank you. Please go ahead. The floor is yours.
There we go. Can you hear me now? Not yet.
Yes, we can.
Yes, we can. All right, there we go. So sorry about the technical issues there. So yeah, I'm Cindy Grande, and June and I are going to be talking about the low barrier model of buprenorphine and its context. We have no conflict of interest to report. Our educational objectives for this session are to identify several distinct models of care for buprenorphine prescribing for opioid use disorder. We're going to compare the relative advantages and disadvantages of each for patients and prescribers, and examine how a family physician might participate in expanding community options for treating opioid use disorder. As we discuss each of the models, please be thinking about the role that you might be able to play in implementing a similar model in your own community. And June at the end is going to actually talk about how she's implementing that in Kittitas County. So this is Jamie Klein. She is a patient from the Olympia Bupe Clinic who was the subject of a major news report and she allowed her picture to be used. She's holding a picture of what she looked like during one of her hospitalizations during her 10 years of heroin injection. And you can see that she's in a much better state now. She's actually got a stable relationship. She's currently pregnant and really looking forward to starting a family. And she's employed, doing extremely well. As you may or may not already know, there are significant benefits to using methadone and buprenorphine in terms of decreased mortality. People that remain on medication have a reduction in their in their overdose mortality, or their mortality overall, close to that of the general population. It's much higher among people who are not in treatment. At the time that buprenorphine became in use in 2002, the federal government, SAMHSA, the Substance Abuse and Mental Health Services Administration, produced a very large document, very impressive, 305 pages, about how this treatment should be used. And it's based on expert opinion, not on evidence, because at that time there wasn't all that much evidence about what the best way was to provide this treatment. However, that expert opinion was the basis of the early waiver training course. As you all probably know, that there's 8 hours of training that is required in order to be able to prescribe buprenorphine to treat opioid use disorder. And that 8 hours is based on this expert opinion from back in 2004. Fortunately, that training has been updated in the past few years, so it's a little bit more up to date with more recent research. A lot of the policies of insurance companies on payment were based on that expert opinion from 2004 and have slowly been changing over time. So that document, known as the TIP 40, which is the basis of what's become known as the traditional model, included a variety of features, including very careful patient selection, choosing only the patients that were considered most likely to succeed with the treatment, baseline blood tests at the first, before starting the treatment, in-office observed induction, which has turned out to be a stumbling block for a lot of people and a lot of clinics to start people because it's very unwieldy and requires people to be sitting around in the waiting room in a very uncomfortable state of opioid withdrawal. Daily or frequent follow-up, which can actually reduce people's willingness to return for care because it's very intrusive in people's lives. A slow upward titration of the dose, about 2 to 4 milligrams per week, which is specified in the TIP 40, while the average dose that's been found to be effective in reducing illicit opioid use is closer to 16 milligrams a day or more. So it would take a while to get up to an effective dose. An emphasis on psychosocial counseling or AA groups or other kinds of peer support was considered fundamental to adequate treatment. And in fact, that has been found to be discouraging to a lot of patients and discouraged them from participating in care, and also discouraged prescribers from being willing to support, to prescribe Suboxone, buprenorphine, because they don't have easy access to professional care, as was described in the previous presentation. Frequent urine testing. It was proposed that urine testing be done at every visit, and there's a lot that's been learned about the effectiveness or lack of effectiveness of urine testing and what its goals should be. Also, it was thought that if the person continues their opioid use, illicit opioid use, despite the prescribed buprenorphine, they should be referred to a higher level of care. And again, as in the previous presentation, we know that that is not a very practical thing to do. There just isn't a higher level of care in most communities. So the University of Washington Alcohol and Drug Abuse Institute has done a series of surveys of people at syringe exchanges in Washington state. And the first one was in 2017 and it was updated in 2019. These are people who are at very high risk of overdose death from illicit opioid use. And in fact, a very small number of people that are illicit users of heroin, injection heroin in particular, very few of them have access to buprenorphine because of that traditional model and all of its constraints. And it turns out that 82% of people who use heroin are actually interested in reducing or quitting use. 56% are very interested, 26% somewhat interested. And those people, when asked what kind of help they would like, most of them would like to have medication. The majority actually are interested now in more detail, in the study showed buprenorphine was the most commonly requested of the medications that are approved for opioid use disorder. So why don't they seek help? Well, they were asked about this, and the most common reason was that they don't trust or like doctors, and they don't want to be lectured or judged about drug use. Again, this traditional model of buprenorphine care results in a way that we deal with patients that makes them feel lectured and judged, unfortunately. In the past 20 years, there's been a lot of research about what actually is effective in keeping people in treatment and saving lives. And it's summarized in an amazing article by Martin from Annals of Internal Medicine. The references for all of these studies that I'm going to talk about are at the end, and Simone will share this PowerPoint with you all. So if you can look at it, I really encourage you to look at this article. The key points are that home induction is equally effective in keeping people in care, and it's not necessary to do in-office induction. Buprenorphine is okay to prescribe even for somebody who's using prescribed or illicit benzodiazepines. Yes, there is a slight increase in risk of overdose death, but it's the risk of overdose death is drastically decreased by the access to buprenorphine, and that far outweighs the increased risk of the benzodiazepine use. If people have a recurrence of use, sometimes known as a relapse, then they should not be discharged from care, but rather extra support should be provided. There have been a number of studies that show that when somebody is discharged from care, that's actually the highest risk of overdose death during that period. So you should really think carefully about whether you're going to just release somebody from care for any reason. Behavioral treatments are optional and have been found to not significantly, I mean, they do have some increased benefit in retention and reduction in overdose death, but the largest benefit, 50% reduction in overdose death, occurs with the medication itself. Drug testing is reasonable to do, but it should not be used as a reason for discharging a patient. Rather, it should lead to conversation about what might have led to the illicit use and whether the patient might think about what other services they could access or how they could protect themselves better from use of those substances. And importantly, that there should be no limit to the duration of the buprenorphine use. Early thoughts were that it should only be used as a transition to pure abstinence over the course of about 6 months. And many insurance companies used to limit the access that they would pay for this to 6 months. And now the policies are, it's understood that people should continue to use buprenorphine as long as it's effective for them, which may be their lifetime for some people. Those changes from all the research of the past 20 years were implemented or codified in the most recent guidelines from the American Society of Addiction Medicine. The low barrier model, also known as low threshold, is a concept that's been developing over the past 20 years, but has really picked up steam in just the past 3 years or so. The basic concepts of low barrier are that it should be easier to access buprenorphine than heroin, that people should have access on the first day that they show up. They should get a prescription that very day. Home induction should be the norm. The harm reduction approach should be the philosophy used in treating these patients. Flexibility in prescribing, including availability of access, dose, and visit frequency, and availability in places where people with opioid use disorder go. The concept of harm reduction is something that's developed over 40 years, I believe, and as described by the National Harm Reduction Coalition, includes reducing the drug-related harm rather than the drug use itself, meeting people where they're at, having a non-judgmental approach and non-coercive manner. Don't try to force people into changing their behavior, letting people decide their own future, which is similar to the patient-centered care that we're all familiar with, and trauma-informed care, recognizing that trauma is actually the gateway to addiction. Almost everybody that has an opioid use disorder or other substance use disorder has some form of trauma in their past. Outcomes with buprenorphine, there's a lot of evidence that it reduces illicit opioid use, improves quality of life, and reduces, in addition to mortality, it also reduces HIV and hepatitis C transmission. Those are all the goals of this kind of care. I'm going to quickly go through a variety of treatment settings that have been used for this low threshold, low barrier model. Primary care clinic, FQHC, which is where June is practicing, homeless shelter, syringe exchange, emergency department, fire department, street medicine, and local jails. And June is going to talk about jails in Kittitas County and also system transformation of how to implement these kinds of practices in a whole community. One of the outcomes that's a key thing in when low barrier philosophy is implemented, these are comments from our clinic. They don't toss you out the door for telling the truth, and I'm always made to feel welcome and that I'm important. These are 3 patients from our clinic and some of their comments. One of the early low threshold programs was at the New York University Medical Center. It was in an adult primary care clinic. They gave the prescription at the first visit, implemented home induction, had weekly and then less frequent follow-up, and they had no mandate for additional psychosocial treatment. And at that time, 2006, that was revolutionary. Study was produced in 2017 about their outcomes at year 7. There were 306 patients represented. They found that the treatment retention on average was 38 weeks, similar to more traditional settings. And they had a 1-week dropout rate of 17%, which is, I believe, similar to traditional settings. There was the Boston Healthcare for the Homeless program, which is still in operation, started in 2008. It's the first MOUD, now it's called Medications for Opioid Use Disorder. That's the new acronym in place of MAT. And the first clinic of that sort at a homeless shelter. They provided buprenorphine treatment, peer counseling, case management, and support groups. One of the early published studies was actually just in 2019 from our own Seattle King County Public Health, sponsored by the University of Washington. And this was a clinic that was started at the downtown Seattle King County Public Health building where they have a syringe exchange. The clinic was opened in 2017, and their study, which I'll show you the results of, had 146 people during their first year. The study showed that there was almost everybody that they tested urine on. They tested urine at every visit and found that almost everybody did have urine positive for buprenorphine, and there was a steady decline in the positivity of the urine for opioids, although it never did go down to 0 for, on average. People continued to use opioids, but they did have good retention in care over that time. This is an interesting graph from that shows that there was a range of different patterns of treatment retention, where some people would start right at the green ones are their first episode of care, and following episodes of care had varying levels of gap in between. And sometimes people would come once every few months, and sometimes people would come very consistently over time, and everything in between. The Olympia Butte Clinic, we opened in January of 2019 at a harm reduction center, Capital Recovery Center, which is a mental health services center that housed the syringe exchange for Thurston County. Walk-in only evening hours. We have peer support as a major component of our services. On-site dispensing of the buprenorphine, which is a fundamental feature of our care. No cost for the medication or for the visits, regardless of insurance. We're very fortunate to have generous grant funding that allows us to do that. Nurse care manager who provides a large amount of the care. We have about 15 community prescribers that alternate among, that share the care, rotating care. And we have a jail justice outreach specialist who who collaborates with the Thurston County Jail. Our volume increased steadily and has reached a point of about 30 patients per day. We're very busy. During the COVID era, we had a significant drop, but at first, but we're getting back up to around 30 per day. I am running short on time. I'm not going to tell you all the details here, but we are studying our outcomes by a Pew Research grant, which is just about to begin, and we'll have some information on our outcomes. We also were able to get the legislation changed in Washington state in order to allow us to have a machine on site for dispensing the medications that will shorten the time to getting people their medicine. Right now, the pharmacy comes and delivers the medicine twice every night, and we'll be able to be quicker once we get this machine in operation. San Francisco started their street medicine program several years ago, and they actually go out to homeless camps and write prescriptions for buprenorphine. That's an amazing thing. We'd love to do that in Olympia. Haven't gotten it going yet. Their study showed from 95 patients, mean age of 39, all heroin use by injection, 100% homeless, and many psychiatric morbidities and substance use. They had patient retention. It looks like it decreased slowly over time. However, this is in comparison with 0. So they found that 23% of the patients were still on buprenorphine even after a year, and that's pretty amazing. Emergency room use was, there's a landmark study from Yale about showing that when the medicine was actually administered in the emergency room for people that came in withdrawal or with some consequence of opioid use disorder, they were much more likely to follow up in care compared to the people that were given a brief intervention advising them about getting care, and those who were simply given a list of places where they could follow up. 78% of the people that actually started the medicine in the emergency room were following up on day 30. That landmark study ended up leading to a whole movement in California where there's dozens of emergency rooms that are now initiating buprenorphine and have links to clinics in their community. Called the ED Bridge program. In Washington state, there are some emergency rooms that are doing it, but it really hasn't caught on yet. Hopefully you in your own community can figure out a way to make it work at your emergency center. There is some amazing leadership. The Tacoma Fire Department has a CARES program, non-emergency medical service. They reach out to their high utilizers. They have a mobile response unit and provide buprenorphine for people that are that had an overdose. And that is really catching people, reaching people where they're at, literally. And they provide close case management also for those people. There's one of the Pew Research grantees is in Ithaca, New York, and their model is very similar to the Olympia Bupe Clinic, but they've implemented a very active telemedicine program where they have actually prescribed buprenorphine now to 200 people by telemedicine alone, which is something that's now only has been allowed just since the start of COVID. They prescribe to people 200 miles away that they've never met in person, using audio, video, or even just telephone. And they've had, this is the report from Judy Griffin, who I talked with, their medical director, who that at 80% 3-month retention rate. Sounds amazing to me, but that's what their statistics show, and a no-show rate of 10%. All right, I'm going to turn this over to June to talk about Kittitas County.
So those of us who work at CHCW in Yakima and in Ellensburg have a MAT, or now MOUD program, Connect, that has been ongoing for several years. And in late fall of 2019, we expanded our care to inmates at the Kittitas County Jail. We initially did that as a traditional part of our program, such that the patients had to be transported from the jail to see us, had all our usual intakes, and that really limited how many people we could serve, because the corrections officers could only transport at a maximum 2 to 3 people a week. So that really limited who we were able to serve. Then COVID hit, and we had people that we could no longer see in clinic, because if the patient was brought to us for healthcare, they would have to be in quarantine for 14 days when they return to the jail, which of course that means somebody living in solitary confinement just because they were looking for care. So it took us a while to figure out how to do telemedicine at our local jail, and it is beginning to work well. So we are now entirely, well, first we just did the telemedicine for the people that we had been continuing to prescribe for, that we had established care before COVID. Then we began enrolling new patients. The contact for us to be able to do that was the liaison person who works at our local community mental health center, who was referring patients based on if they were already on Suboxone prior to their incarceration and their community provider was unwilling to write those prescriptions while they were in corrections, or people that would be staying in our community and would be following up with us. Our jail actually has a large number of inmates from other parts of the state because we have excess capacity. So we have inmates from the West Side. We have inmates from Spokane. We have inmates awaiting federal charges. So we at this moment, we can only target, folks that already are continuing their Suboxone or are going to be local with us. Right now, we're averaging at least 5 patient visits a week. And as Cindy said, we're now, it is possible to do this entirely by telehealth. Sometimes it's phone, sometimes it's Zoom, depending on the connections with the jail. And that's a complex issue all in itself as far as internet connections, allowing the patients to have access to that. We've had to make some accommodations. But what I've learned is we are beginning to see more and more people. So we have now served 35 patients in our program so far in the last year. And for a small county that only has 40,000 residents, I think that's a pretty significant inroad. There's also a lot more dignity and privacy than dragging somebody into our clinic through the back door in shackles and an orange jumpsuit to see their provider. And being able to really establish and see that face on the screen when somebody is still at the jail, and the relationships we're forming are getting them to see us after they're released. We are always able to see them within 3 to 5 days after they're released. Their prescription is ongoing. We've already had the talk with them saying we are not part of the correction system. Our urine drug screens will not, be turned into your probation officer. This is your health care. This is a critical time frame to get people on and keep people on Suboxone, because there's a more than 100% increased risk of fatal overdose when people are released from from correction systems because they've lost their tolerance and they go back to their old dose. So we really feel that this is just a huge need that we need to meet in our county. So now if you can go on to the next slide, what we're doing with the folks in corrections is part of our our greater challenge as part of the Kittitas Health Alliance initiative. It's through the ACH. Our county health alliance, it has a grant that is not only related to Suboxone, but addressing a variety of social determinants. But we are, as a part of this grant, developing a county-wide coordinated opioid response plan that will include the hospital, including training and willingness of emergency room doctors to begin prescribing, using our community mental health outreach person as the hub to then refer those people to providers in the community that will continue prescribing. That's at our clinic as well as the 2 clinics affiliated with our critical access rural hospital. It includes the outreach worker at the jail that is referring people to us. As regarding the opioid response plan, part of the grant, Dr. John Azrael, who many of you know worked at our clinic for many years, has now essentially a 0.5 FTE full-time doing the teaching and beginning to figure out how are we going to utilize our emergency room physicians so that they don't feel like, oh, they're just going to come. The statements that have been made to me before this training was, they're just going to come to us every time they don't manage to get to their visit. And I don't just want to be using an emergency room visit to prescribe their Suboxone. And so we have to change those attitudes, also getting our hospitalists to be consistent in trying to transition people to Suboxone, because again, when somebody has a serious overdose and is in the ED, gets hospitalized, that is a perfect time for intervention. So there's a lot of, we're in a small county, we're blessed to be able to have the FQHC and the Critical Access Hospital and community mental health and police and fire and community agencies and substance use outpatient treatment all beginning to work together on this. So it's not up and running yet, but it is something that we're excited that we are going to continue to implement in our county.
So what they're doing in Kittitas County, it's the complexity of that is obviously something that is going to make it take a while to get up and running. And they're doing an amazing job there, really bringing in all aspects of the community to solve some of these really difficult entrenched problems. One example of another large system transformation that is in that context is really amazing. Over the past couple of years, Missouri has a program called Medication First that was funded by the state through the State Targeted Response grant, federal grant, with 14 state contracted treatment agencies at 38 sites, and they got them all to transition to low barrier model, shortening their time to the first dose from 8 days to 0 days. So treating people on the first day that they showed up. They had an increase in their utilization of buprenorphine up to 44.8 to 85%. And honestly, I don't remember exactly how they measured that, but it was a remarkable, swift and drastic transformation of the care at those sites. And they found that they had reduced their cost for taking care of people with opioid use disorder by 21%. I'm just going to quickly mention that there is a movement afoot at the national level to end the requirement for a waiver for buprenorphine. And there's a congressional act, or bill called the Mainstreaming Addiction Treatment Act. And it may actually, it's been specified by President-elect Biden as something to be accomplished during his first 100 days. And there is a movement in Washington State to help with that. And if anybody is interested in collaborating with me to try to help move things forward from our state's level, please reach out to me, and I'd love to talk with you. So thank you, and I'm going to stop sharing my screen now.
Thank you, Cindy and June. I'll handle the questions. So there is a comment and a question by Nancy. Concern about people's follow-up to the visits and providing urine and sometimes refusing to provide urine for testing. Of course, there are worries that is the person selling those medications in the street? So the question, and I will add one part to it, is there evidence that intermittent use of buprenorphine is effective, in a sense, leading to the effect that we want? And the part that I am adding, is there harm from doing that, whether that's to the person using it or to the ones who are intermittently using some of it?
I'm just going to look at the beginning of that because I was a little distracted at the beginning of that. Has to do with urine testing. I'm sorry, can you just read the
Yeah, so they're repeating the question. So people, one of the challenges that they're prescribing, Nancy is describing individuals not coming to follow up as a challenge, or individuals not providing urine for testing. So I would change that into a question for you. How do you deal with such challenges? And then the second part of the question that I would also modify for you is there harm or benefit? Can you discuss the harm and benefit of intermittently using buprenorphine?
Yeah, okay. So the question about not coming for follow-up visits, that's a really key question, because I also prescribe buprenorphine in my primary care clinic. And that is a reason that I have had to discharge patients, because if they don't show up repeatedly, then that's taking space away from somebody else on my schedule somebody else that would like to be on my schedule. And so that's a reason that can be a real hardship for those of us in primary care. And it was one of the guiding things that caused me to want to get to work on the Olympia Bupe Clinic. Yeah, you can't have your clinic revolve around people that often don't show up. So that's why the walk-in model is really a better model, and it may or may not fit into your existing clinic structure. If you are able to develop some kind of a separate program within your clinic that allows people to walk in and get service, then you don't have to worry about those missed visits. As far as whether it harms people, well, what has been found is that as much as people use, whenever they're using buprenorphine, they're at lower risk of overdose death and all the harms associated with injection drug use. So even if it's intermittent, then that's way better than not doing it at all. So that, I hope that answers that question.
So to comment then, some may argue, even if somebody actually buys it from that individual from the street, maybe that person who's buying it and using it also getting some benefit. Would you see that as a point potentially, or that's kind of a shady way of interpreting?
No, I agree with that totally. And in fact, I think the vast majority of our patients who have never been in an MAT program have already tried Suboxone. Now, they may not be using it correctly and know that they have to let it dissolve sublingually and things. Most people have tried it. I think the only time we struggle with occasionally discharging somebody, if they're clearly only using their Suboxone when they can't get their heroin supply and they have no intention of quitting, and they really are selling their Suboxone primarily to get heroin. In that case, we're not doing that patient any good. But that is the small exception rather than the rule. I would rather have somebody be partway compliant, and as Cindy says, the less heroin that gets used, the less harm that's done, and the more people that buy it off the I know that some of the Suboxone that I prescribe gets to other people, and I hope that it then leads to them coming into treatment.
Yeah, that's a really important point, is that people who get, we know that a lot of the prescriptions that we write, some of it is going to people other than the people we prescribe it to, and that's true in traditional settings and in low barrier settings. But those people who are getting access to it on the street are more likely to then come in and get their own prescription over time. And certainly those people are at lower risk of the adverse effects of the illicit opioid use. We are highly aware of the DEA being watching for that. And so it's really important at the Olympia Bupe Clinic that we try to minimize those people who are coming in and just getting the buprenorphine in order to sell it. That, like June said, we found that to be a really small number of people. of people who are specifically trying to come in just to get something that they can sell. It's much more common that people might just share or sell a small amount of their medicine.
Another set of questions by Nancy is, what are the barriers to prescribing for inmates from other jurisdictions? Second question, would they be included in your limited number of allowed patients? And then, are there issues with identifying follow-up prescribers after release?
As far as barriers, I think it's more prioritizing until we can, we don't have enough availability right now to serve much beyond our own county. On the patient's end, there's a big barrier because unlike the large county corrections facilities, we don't have in-house full medical care provided at our jail, and people who are inmates in our county have to pay for their health care. Patients get charged, and I've just learned that it's a really funky sliding scale depending on what their restitution requirements, how much the jail is charging them to see us, even though, we're charging the jail a reduced rate, but then the jail is turning around and charging those inmates for their medicine and for the visit. And that's a whole issue in prison reform and jail reform that we need to be aware of, because that's for mental health care and physical health care as well for people that are in jail systems. When they're people that are from the West Side or from Spokane, those are typically areas that have hub and spokes, and we will link with other hub and spokes if we have somebody from other jurisdictions. So it's just, it was really just, we need more funding, more bodies, and quite frankly, we need reform of payment so that the patient is not footing the cost because their insurance has been suspended because they're incarcerated.
So regarding the question about are they included in your limited number of allowed patients, the limit to number of patients is rarely a practical factor, except maybe for the people that are prescribing specifically in jails and that have a large jail like the King County Jail. I'm not sure, June, have you had to deal with concerns about reaching your limit?
No, because we have 3 prescribers in our clinic. So between the 3 of us, we don't hit that number.
But the follow-up to other clinics after release from jail is a huge issue that all the jails would have to deal with somehow in order to get the best benefit for their patients.
Thank you both. Question from Gerald about concern for organized crime, potentially, retaliating against providers who are prescribing. Have that been your experience, or have that been raised as a concern among the group who do that?
I have not run into that, or in any of the stuff that I've read about other clinics, that has not turned up to be an issue.
I'll ask one question from me. Perception. What's your perception of the reluctance among providers to prescribe medication-assisted treatment, and how do you provide support and address such hesitancy?
Yeah, well, that is a huge issue. There are, I believe, about between 10 and 15% of people who are candidates to get licensed to get a waiver that actually have a waiver, and of those people that have the waiver, a very small number of them actually prescribe, and then fewer of those people are up to their limit. There's so many barriers to prescribing, and some of them we've talked about, like people that don't show up for visits, and other concerns about the potential impact on their clinic flow, like worries about whether they had to do home induction in the office, and also administrative barriers and lack of support from their clinic. If they can take a leadership role and advocate for getting it going in their clinic, I'm certainly willing to help, and people can reach out to me. There's the Providers Clinical Support System, which is a national network that will provide counseling or mentoring. And there's a whole range of technical services that are available at the national and local level. If you are thinking you'd like to do it and you just want some advice about how to get going, please reach out to me and I can point you to resources that might help you in your setting.
Thank you very much. June and Cindy, we're running out of time. So Gina's asking quite the complex question that I would love to answer, but maybe we can reach out to you, Gina, after the session and we can comment.
And if people have already read the chat box, I want to say maybe one or two words to Gina's question. I think that it's key that because I'm in a clinic that is way along the way of integrated behavioral health. We are really, and we have a liaison in our clinic to get people to the community mental health, but we also do a lot of mental health in our clinic. We require every one of our Connect patients to have a primary care physician in our clinic, and we really work on addressing the mental health triggers. You have to treat both or it's not successful.
Can I just take 10 seconds about, I'm just reading a little bit about the highest goal for their community is to not just avoid death. That's an important thing from a medical standpoint, but what we're dealing with at the Bupe Clinic and the other low barrier clinics, we want people to get their lives back, re-engage in culture, community, and family, and develop attachments and strength in their relationships with other people. There's huge quality of life issues that you can, the first step is just to get people on the medicine and then you can move from there. So thank you very much for that question, Gina.
Yeah, it's a very thoughtful question. Yes, and thank you also to you, Cindy and June, for this thoughtful, engaging presentation and very encouraging. Appreciate all your efforts. Without further ado, we'll move to our next presentation by Dr. Ying Zhang and Dr. Christina Miles. This is going to be case discussion